Respected panelists of the session, distinguished audience, good morning. I am Dr. Abdul Jabbar. Welcome all of you to my part of presentation on life-saving intervention to save drug-dependent pulmonary circulation. Newborn with drug-dependent pulmonary blood flow require palliation until more definitive surgery can be performed. Historically, palliative procedure of choice was surgical modified petition, but this procedure has significant morbidity and mortality, so transcatheter PDA stenting has emerged as an attractive alternative. Today, I would like to share with three different cases of pulmonary atresia having defined morphology of PDA, go through defined approaches for ductal stenting. A 6 hours old newborn presented with central cyanosis and respiratory distress with saturation of 55%. ABG showed metabolic acidosis hypoxemia, chest X-ray showed oligemic lung field, pulmonary conus is concave, apex is tilted. An echocardiogram showed pulmonary atresia with BSD with PDA dependent pulmonary circulation, but origin of the PDA, source of PDA was not clearly documented during perioperative echocardiogram preoperative. So we start prostaglandin, saturation increased little bit. So plan for ductal stenting. So femoral arterial root was judged, angiography done. When we introduced the wire, it goes through brachiocephalic artery, base of the brachiocephalic artery to across the PDA to the confluent. And this is indirect PDA with long in size, about 24 millimeter long stent was placed. After ductal stenting, good arborization and arch also delineation was done. So discharge the child with stable condition with 85% saturation in room air. Another 3 days old newborn presented with respiratory distress with cyanosis. On examination, there was low saturation 50% in only, having continuous murmur. ABG showed severe metabolic associated hypoxemia, chest X-ray showed RP apex with oligemic lung field, ECG right axis deviation, right ventricular hypertrophy, and echocardiogram showed membranous pulmonary atresia with intake IBS and usual drug-dependent pulmonary circulation. So prostaglandin was started, saturation increased little bit, and plan for ductal stenting or pulmonary, it was membranous, so also have mind for pulmonary valve perforation. RB angiogram showed IB was little borderline, infundibulum was good in size, RB outflow tract was adequate. So gentle negotiation with CT wire, pulmonary valve is perforated successfully and it goes through PDA to descending aorta. Confirmation done, check angiogram. Catheter, she faced difficulty during catheter manipulation through pulmonary valve. So initially, balloon dilatation done through coronary balloon to dilate, and later on large pressure to balloon was negotiated and balloon dilatation was done. Successfully, and after balloon dilatation with dissect balloon, good integrate flow was ensured, noted. And saturation was increased up to 85% post pulmonary valve perforation echo showed. This is RT was a little borderline and integrate flow was established across the pulmonary valve. Another child, that is 1 year 5 months, presented with deepening of cyanosis, having gasping respiration, admitted to cardiac ICU with acidotic breathing. Chest X-ray showed situs inversus dextrocardia. ECG showed poor RI progression. Echocardiogram showed complete abicanal defect, situs inversus, complete abicanal defect, having direct PDA from under surface of the arch with restrictive in pattern. Ultrasonography revealed asplenia. After stabilization, saturation increased up to 60%. Surgical consultation taken. There was hypoplastic dense pulmonary arteries, so they refuse at this stage. Go for angiogram. Arch angiogram in lateral and RO position, PDA was not delineated clearly. Go through right axillary approach, and PDA originated from under surface of the arch, and stenting of the vertical duct tunnel, and post-op echo showed good antigrade flow, stenting pseudo, and can discharge the patient with 85% saturation. So PD stenting for ductal dependent circumferential Zibon is safe and effective. Some patients have to face difficulties perioperatively due to complexity of the shape of the PD and transpulmonary arteries, origin abnormalities. Needs more and more expertization and clinical decision. I'd like to acknowledge my department, our head of the department, Professor Dr. Rejona Rima Madam, and all the doctors, staffs, and technicians. Thank you all.
Thank you, Jabbar. Very challenging cases in different age group.